Hey everyone, my name is Garrett Oyama. I'm a professional musician, PhD student studying communication in the brain, and a practicing speech-language pathologist. I'm the host of Beyond Words, a new podcast exploring the rich space where language, music, and cognition converge. If you're an SLP who's ever been curious about the mysterious origins of language, or how organized sound in the form of speech or music can affect us so deeply, or the relationship to other functions of the brain, then this show is for you. On this show, we dive into conversations that span the spectrum of human communication, from the way that infants amazingly use things like statistical probability to learn the sounds of their mother tongue, to how music and language intersect. This podcast is brought to you by SpeechTherapyPD.com, and the episodes are available for 0.1 ASHA CEUs through their website. So what lies beyond the words we speak? Tune in on your favorite podcast platform and find out.
Welcome back to School of Speech, presented by Speech Therapy PD. I'm your host, Carolyn Dolby. Today, we are diving into a topic that can feel a little intimidating, treating childhood apraxia of speech. We have Mike Bright. He is a seasoned SLP with nearly 20 years of experience. He's here. He's going to break down definitions, share strategies, and give us some practical tools. So if you have ever wondered how to balance best practices with the realities of your caseload, this episode is for you. And don't forget, you can earn 0.1 ASHA CEUs by completing the course modules on SpeechTherapyPD.com. Now let's get on with the show. All right, hello everybody, and welcome to School of Speech. I'm your podcast host, Carolyn Dolby. I am so glad you have tuned in today. School of Speech is presented by Speech Therapy PD, and today we have Mike Bright with us, and we will be making it work treating apraxia and motor disorders in schools. Well, Mike is perfect for this. He is a speech-language pathologist, and with nearly 20 years of experience helping children communicate. He's been trained through Boston Children's Hospital through 2020. He's developed an expertise in thinking about particularly difficult to understand speech. Mike was selected for the inaugural boot camp provided through Apraxia-Kids, and he is recognized by that organization for advanced training and clinical expertise in childhood apraxia of speech. He has received intensive training, subsequent in-depth experience working with a variety of complex speech needs. He enjoys also helping children and family navigating that murky and often stormy waters with the diagnosis and appropriate treatment, and also with progress monitoring. So, all right, y'all, I know you all are here because I'm just as interested as you guys, so I'm so excited. Just some housekeeping. Each episode of School of Speech is offered for ASHA 0.1 CEUs. Next, for financial disclosures, he owns and receives compensation from Bright Speech and Language, and he also is compensated for consultation and mentorship services run through Childhood Apraxia, CAS study group. Sorry, I don't know where I was going. It's going rogue there, Mike. I was going rogue. Non-financial, he is recognized, I think I said, Apraxia-Kids for advanced training and clinical expertise in childhood apraxia of speech. He is also on the advisory, he's an advisory board member of SLP Nerdcast. For me, I am a salaried employee. Ooh, KK Oregon, me too. Sorry, I was a shout out to a listener. I'm an employee of Portland Public Schools in Portland, Oregon. I also receive compensation from Speech Therapy PD for hosting School of Speech. Non-financial, I do consult for school districts across the nation, helping them set up their dysphagia programs and train their staff. Enough about me. I really want to know more about Mike. Like, heck, Mike, who are you? Why are you here? And what do you have to offer? And I already know what, but that's so funny to me. Tell us your journey, because we are listening minds. Here we go.
Excellent. Well, thank you for having me. It's nice to chat with you and meet you, Carolyn. And
I love it.
I'm so excited that we've got so many people listening. It's an honor to be able to get in people's ears. And
I know. I am looking
that's
here.
Going to be helpful.
We've got people from all over the place. I see a couple of Oregon people. Shout out Oregon. Love it. And you're where are you, Mike? You're on the East Coast.
Yeah, I'm in Massachusetts, just outside of Boston. So
there's somebody on here from Massachusetts I saw too.
I think I saw that bubble up as well. But yeah, you gave a lot of words about where I've come from. Just to share a little more context, I think it's helpful to know that when I was working at Boston Children's, we were trained, like many, to be generalists, where you
Mm-hmm.
see whoever's coming through your door. And I know that's something that is particular to school-based speech pathologists as well. One thing that I also took advantage of was they encouraged specialization at the hospital. And it turned out that no one really was a specialist in motor speech disorders there. And I kind of very timidly raised my hand as someone who might be interested because I had this friend on my caseload, 13-year-old. You could understand what he said, but he sounded really unusual. And I knew he had this diagnosis of apraxia, and I knew he sounded unusual, and I was there trying to figure it out. And very quickly figured out that I didn't really know what I was doing, and then was very fortunate to get connected with Apraxia-Kids when they were starting up their boot camp program. Just a little bookmark in there for anyone who's looking to learn more. Apraxia-Kids is a fantastic website with lots of free resources, a lot of pre-recorded information, and they also run this boot camp every year for 20 or so speech pathologists around the country and also Canada, where you can go and sit with like the experts in the field and get 4 days of really intensive training. So that kind of kicked things off for me, that boot camp experience. And afterwards, the hospital set up this like triage system where everyone who would come through the doors and there was some concern for motor speech made their way through my office. So kind of through that experience, I had the opportunity to hear a lot of kids where there was a question of childhood apraxia of speech. Not necessarily everyone had childhood apraxia of speech. And one of the tricky things about childhood apraxia of speech is there's no one way that a child might sound that is indicative of childhood apraxia of speech necessarily. There's all these little things, all these little symptoms that we kind of have to tune our ears to in order to hear it. But I really developed my own kind of listening library as I worked with all those kids and families and was able to develop a specialization there. So I really do have, I don't know, a very specific and kind of privileged background to have worked with so many kids and families who have had this question of, is this apraxia? If it is, what do we want to do with it? So yeah, I'm happy to kind of bring some of that to your listeners tonight. And another non-financial disclaimer, I'm not a school-based speech pathologist. So I'm going to try to tailor this to the folks on this call, but I also really encourage folks to jump in on the chat and ask questions if there's things that are particular to your setting, or even if there's cases that you're thinking about. I really like thinking through things that way and making it more of a conversation than just talking. So with that, yeah, I'll bounce it back to you, Carolyn.
Yeah, well, first of all, I am a total novice when it comes to apraxia of speech. So I wouldn't mind if we kind of took like a step back before jumping in to kind of step back, and if we could like maybe define it for me, really, because maybe give us, I like a bit of a background, like, because it can be, like you said, that if there's not like a specific thing we need to listen for, like, what would you define it as? How do you define it?
Well, yeah, let me also throw in the first disclaimer of the night, which is we've got an hour to talk, which is completely insufficient to talk about any of the areas that we could go, let alone all of the areas. But I'm going to do my best. And I think one way that is helpful to contextualize things is to think about all the things that we do as speakers. How do we have an idea and get it out? I think there's a couple different, there are many different things along the way. And if you think about them as a chain that kind of links up with one sequence happening before the other, that's a adequate metaphor to kind of help guide us through. But if the first link in the chain is the idea, you have an idea of wanting to say something like, how about book? You wanted to say book. You have the idea of book, and then you have communicative intent. I know I can get this idea of book into Carolyn's mind from my mind because she's a listener and she can have a perspective. So I'm going to communicate with her. That's that second link on the chain. After that, we need to have a semantic representation. We have to have that word book so that we've got like that dictionary that maps the book itself onto a word. And the step after that is where the phonological assembly happens. So where you're actually selecting the sounds, the book, and you're getting them in that order. So all of that happens even before the muscles get involved at all. And lots of kids on our caseloads have difficulties premotor in either selecting the sounds, developing the vocabulary, establishing communicative intent, possibly with their cognition. But all of that kind of happens before the motor system kind of comes online. But the next links in the chain are where sometimes we see breakdown for kids. And if it is in what we call the planning and programming of how their speech muscles are moving, we would say that they have childhood apraxia of speech. Now, what the heck is planning and programming? Two very similar sounding words, but another way to think about them is the strategies and the tactics that we use in order to speak, and taking it away from speech and putting it in kind of the context of something that you might do in sports. If I throw you a ball, Carolyn, you have the strategy of, I got to put my hands up. There it is. You got to put your hands up. So in doing that, you selected a strategy of putting your hand up, which involved some arm muscles. You opened your hand, and then the tactics are going to be the speed at which some of your muscles need to move, the joint stiffness around those muscles in order to support the movement, the timing so that you actually catch the ball and it doesn't bounce off your hand, the force with which you're moving so you don't crush the ball. And we do all of those things, whether we're catching a ball or whether we're speaking, we do it like that. And we do it like that even before we start to move, which is incredible. It's mind-blowing. We do it without even thinking. But when kids have difficulties in that area of planning or programming speech movements, there's certain symptoms that kind of bubble up as it making us think that there might be something in need of support there. And I'll point folks towards a couple resources there, but the 2007 ASHA technical report on childhood apraxia of speech is a long one, but it's very readable. And that kind of will take you through all of the things that kind of get to this point where they're saying there's these three main features that help us think that childhood apraxia of speech might be something going on for someone. And I feel like even it's going to be a disservice to I'll just mention them, because if I don't, like, what the heck?
I know.
Mike. But the first is token-to-token variability. That's basically when something sounds different each time that you say it. And there are ways that I'm getting into it.
I know.
Get into it. There are ways that token-to-token variability can make our ears think motor rather than phonology. Because if there's a child who's kind of developing their phonological system, they might mark a certain sound. Sometimes they say a word, but not others, or they might mark it in one word position, but not another. That type of inconsistency is phonological. It's representational. It's about how the sounds live and work, but it's not about how the muscles are moving. When we think about token-to-token variability in the motoric context, it's these kind of near misses, or was that an in book, or was it more of an some kind of an in-between sound where at one time it's book and the other time it's book, or it's a slowed transition between those sounds where you think, oh, what happened there? In the movement, what happened? Not necessarily in which sounds were selected, because again, that's premotor, but how was the movement pulled off by the muscles that are responsible for making those sounds? So that's the first one, is this token-to-token variability. The second one I kind of demonstrated also, which is lengthened or disrupted co-articulatory transitions. So as you're moving through a word, is there a break or a hesitation or a prolongation in something that someone is trying to say that makes us again think, hey, it wasn't a sound error, it was a movement error, if that makes sense.
No, I see where you're going. Keep going. What's that third one?
Yeah, so the third one is, and this is one of the things that really caught me off guard about that friend that I mentioned up top, was that there's prosodic deficits. And by prosody, I'm referring to rate, I'm referring to intonation and stress marking. So as I'm talking, I'm varying my rate, I'm emphasizing certain words by making them louder and longer, and that's marking stress. And then my intonation, my pitch is going up and down. And I'm doing it without even thinking about it, but I do it for a communicative function of hopefully making myself a little bit interesting to listen to, or by drawing attention to a specific word, things like that. Kids with a childhood apraxia of speech are often working so hard to coordinate the movements in their mouth to make the sounds that they don't have the resources to then control breath support or laryngeal tension, or even velopharyngeal valving in a way that makes sounds either come orally or nasal. And so we hear very specific, we hear very awkward sounding prosody, whether it's either that sounds robotic and kind of monotone and flat, or we say, ooh, that just sounds odd or
Different.
off. Or
Yeah.
they're saying instead of computer, it's computer, things like that, where things are just marked a little bit unusually. And that those are things that we usually are noticing with the kids who are primarily phonological.
Hey, I
yeah.
just wanted to stop for just a second. So, because I was just, you had those three features. I got the token to token variability, and then the third one was the prosody, but I missed that middle one, and so did Greg. So
Yeah, it's lengthened or disrupted co-articulatory transitions. So that's when, in the word book, I either lengthen it, book, or I somehow might actually turn my voice off, book, where I kind of am able to move between a sound and a consonant and a vowel, but I can't continue that movement to another consonant, so I have to turn my voice off. In computer might be a better word to demonstrate it, where it could be computer, where there's this kind of halting breaks between syllables. Those syllables get segmented. And kids with childhood apraxia of speech are often demonstrating difficulties in those areas. And let me just take a step back, because I think I kind of alluded to this, but childhood apraxia of speech can look so many different ways. And in these three features, there's not one that has been designated as you need to have this in order to have childhood apraxia of speech. It's not like you need to have more 2 out of 3. It would be nice if there was that kind of if-then correlation, but the diagnosis is made based on the gold standard of diagnosis is expert clinician judgment, which is like, really unfortunate when you are someone who is just seeing your first child with childhood apraxia of speech. It might be written on the IEP, or you're just seeing this child for your first evaluation as they're coming in from early intervention into your preschool program, and you're trying to think, hold on, could this be childhood apraxia of speech? If you haven't seen hundreds or thousands of kids where this is going on, it's a really tough diagnosis, which is why there's folks like me and folks through Apraxia-Kids who are trying to get the information out there, so that we can be these beacons or these resources around the country where folks can refer for a diagnosis.
Yeah, so going back to saying that, the diagnosis must be done by an expert clinician, how do we know? I would definitely not be an expert clinician.
Yeah. So hopefully there would be someone in your district who would have some experience with motor speech disorders, or if not, hopefully they would recognize, hey, I think this might be childhood apraxia of speech, but I don't have the chops or the experience to make this diagnosis. I need to refer out to the community.
Okay.
And I know that can be dicey and tricky with administrators, but I think it's also a responsible decision, and maybe we're going to get into some of this, because the treatment that's effective for this type of movement difficulty is different than the treatment that we know mostly for kids with phonological disorders or developmental language disorder, or a variety of the other more common things. So it's an important diagnosis because it really does point you in a different way for treatment.
Okay. I just feel like nudging in the back of my head is that in the schools that we would want an outside diagnosis of that to confirm that.
And it's something that I help school systems with.
Okay, yeah.
So I've done anything from coming in for an evaluation at the school where I'm performing the evaluation and doing the diagnostic, to being a Zoom computer on the wall while a clinician there with some pre-training and support does the assessment, and we're talking about it afterwards. And even relationships where there's some ongoing staff training afterwards, because you get the diagnosis and then, got to actually work with this child for the next probably couple years because it's something that is pretty significant in terms of a communication impairment and requires some pretty intensive service. So yeah, there are resources out there. And I think it takes some bravery to step up and say, yeah, I don't really know what to do with this, but I know that I need to call in somebody who does.
Yeah, and I think it is important. And Sophie, I want you to know that I was going to send you and say, hey, I saw you've got some a request about, and I'm going to get to the jaw grading maybe when we get a little bit into some other things. But I wanted to mention that she's right that in schools we do a lot of traditional therapies, and we really this is so important to talk about motor planning and what we're doing tonight. And so could you give us a little, maybe, I mean, I know we only have an hour tonight, but a little bit more of what does an assessment look like? I know we can't, you're not going to be an expert clinician unless you already are right now, but this is at least going to be some tools in your toolbox leaving tonight, hopefully. So what would your, just key points of your assessment?
Sure. The thing that jumps to mind first is there is a clinician, Jenya Iannuzzi-Siegel. She's out of Marquette, I think. And she has an article out, which is a tutorial on using something called the ProCAD, PRO/CAD. And basically what that is an observational rating form. Thank you for putting that in the chat. It's an observational rating form that basically you're using 3 separate speech tasks to look for these symptoms of motoric involvement. Because what we didn't even talk about, because we got into the apraxia world, is there's this whole other thing called dysarthria, which is, hey, your planning and programming could be fine, but you might not have the strength to execute those movements. And that is something called dysarthria, which is another motor speech disorder. But there's a lot of overlap between apraxia and dysarthria. And in fact, there's a lot of overlap where kids have childhood apraxia of speech and dysarthria, and they have either a phonological delay or a phonological disorder, and they need help with their language. So like it doesn't live in a vacuum. But being able to separate things and say, aha, that right there is a symptom that makes me think that movement between sounds is something that this child needs help with. And that makes me want to use this approach that's going to really support that, versus that really sounds like a sound substitution. It's an unusual one. It's not even something that I've heard a kid do before, and the kid doesn't do it all the time. But it's making me think more about how that child is retrieving sounds or assembling sounds in that premotor phonological space. And that is actually where I want to spend my energy. But back to your question about what does a diagnostic look like? I want to hear the child speak in a lot of different ways. I'll use a single word articulation assessment just because I want to get an inventory of what sounds this child has, their independent inventory, what their phonotactic inventory looks like, i.e. what syllable shapes they have, do they have consonant clusters, but I'm kind of gathering information. But in that, while those observations, are they using any developmental or unusual sound substitutions or omissions? So those are observations about how the phonological system might be developing. I'm also listening for those symptoms of motoric involvement. On the Goldman-Fristow, we've got vegetable, we've got elephant, some of those longer words where we might hear a child have some of those motoric symptoms bubble up. Or it might even be on simpler words where we hear, hold on, there was a vowel in that when that child said boy. I don't know if that was really boy or it sounded like a boy, where there was like some unusual movement there. They kind of got to the boy, but it came through an unusual route, which is making me think, hold on, something happened there in the movement to achieve that diphthong, which is a vowel that has some movement, and makes me think, I want to dig deeper into motor. So there's this single word articulation test. There's also this idea of dynamic assessment, which hopefully is something that is spreading throughout the field, but it is in this motor speech realm. There's an assessment called the DEMS, the Diagnostic Evaluation of Motor Speech Skill, which is developed by Edie Strand. And that is basically a single word test where I am able to find out not only what is a child's production like across a variety of increasingly complex speech movements, but how can they benefit from my cues? If I try to help them to say something like banana, are they able to benefit from my cues in getting the movement to be more accurate? And if so, what happens when I pull my cues back? Can they keep that and maintain that benefit, or do they fall apart again? And that kind of back and forth dance of what supports are helpful and how are you able to hold on to them as a speaker, or conversely, how much do you need my support, can really give some important information about how the speech system is developing. If you don't have access to the DEMS, you can use your own word probes where you're basically trying to get in there and see if you can help the speech system move more efficiently. And if you are, you're kind of giving yourself your treatment plan by saying, okay, this was helpful for this child. I think this child needs more of this. And then I think the last part, there's plenty more, but the last part that I think would be important in a speech eval, looking specifically for motor speech, is something connected, where you're speaking in a phrase or sentence level, where we can hear not only a movement within a word, but a movement between words. And so that could be something like a sentence repetition task, something like the buy Bobby a puppy task, which is another one for your listeners to look at, again, by the same researcher. If you look up buy Bobby a puppy, there's a nice little visual that goes along with it. It's a very quick thing to administer. But the thing about that phrase, buy Bobby a puppy, is it requires some really specific jaw grading, and it requires some voice onset timing. We didn't talk so much about voicing, but the difference between "b" and "p" is very precise coordination. And so it gives access to hear a child say that 5 times, and you kind of analyze, are there any differences between those productions? And then sometimes with older students, I'm doing like a story retell to say, okay, here's my story. You can retell it with or without pictures. And again, we get a sample of how is that speech sounding in connected speech. And I'm going to pause right after this. I promise I can really get on the run. But this is the speech part of the eval. I really also want to know how the language system is developing, how they're understanding, how they're able to put words together in more grammatical features. I would love to know about their pragmatics, because this is all basically, it's in a good speech eval, it's a communication eval, and we get to kind of prioritize our treatment targets based on how something is or isn't standing out from everything else.
Yeah, one of our listeners indicated that it sounds like, things should be separate and clear, but it's really, to me, it's sounding like there's so much overlap.
Yep.
It sounds like this, it sounds like that. It's really complicated.
Yeah, and it sounds different in a child who is not yet really speaking, and they're just trying to get their speech system up and going, and it's never really been working for them, from a middle schooler who's been dealing with it their whole lives and has more speech under their belt. The features are going to change over time, and if this child's been getting good treatment, we also expect the symptoms to be shifting. So again, it requires a sensitive ear to be identifying the features, but I wonder if it would be helpful, and tell me if you think so or not. If we imagine that the folks on the call have an IEP in their hand and it's got a diagnosis already there. It says childhood apraxia of speech, and now it's like, well, what the heck do I do with this?
You know what? That, for our time today, I think that would be good. So, because I think honestly, I think there's so many questions. I mean, we've got so many questions just popping at us, that if you would be willing, maybe we could do one that is about assessment another time. And I think because we have a lot of treatment questions as well. So if we could, starting right now, we are going to be like, we have that IEP in our hand. I love that. The IEP with the diagnosis already given to us that they have childhood apraxia of speech. What do we do? Which kind of brings me back, which you can start with that, but we also, you start with that, because then there was a question about jaw grading. I want to remember to ask about that, and just tips for early intervention too. So, all right, we have an IEP. We have a child on our caseload now with childhood apraxia of speech. What do we do?
Yeah. So, and again, we could spend, I present about this stuff, and we take like 4 hours to do treatment. and we take 4 hours to do diagnostics. So this is all necessarily very surface. And at the end, I'm definitely going to share some more resources where folks can learn more. But I think the most helpful, I think it might be helpful also to frame it in this idea of what's the best case scenario and what's the reality of working in a school where you've got a gigantic caseload and you've got to see everybody all the time and you don't have a ton of time. But I think starting with the ideal situation is helpful to know, because again, going back to that position paper on apraxia from 2007 from ASHA, the recommendation, particularly for kids who have limited or very impaired speech with childhood apraxia of speech, is these kids need 3 or 4 times a week working really hard to make these muscles move for speech again and again and again. I'm realizing also I didn't give you your definition of childhood apraxia of speech. So I'll see if I can sneak that in. But the treatment intensity, getting 4 times a week at a school, I know is like probably unheard of in a lot of places. But I think it's important for people to know that the research supports the need for that intensity of service for these kids to be able to make progress. And so maybe with some of the resources that I can connect you with, you can go talk to your administrator and say, hey, this kid needs more than twice a week, or else we're not going to make progress. I can work my tail off twice a week, but it's just not enough opportunity, because what we're trying to do, I'll give one of my favorite metaphors or analogies. I probably should know which one it is, but I don't. If we imagine a cornfield where we're standing on the outside and there's some scarecrows in the middle of the field, and we want to walk from the outside of the field into the field to find one of those scarecrows. By walking that path, we mat down the corn and we find the scarecrow. The more times we walk that path, the easier it is to find that particular scarecrow. We've developed a pathway, and that now becomes easier, more efficient for us to do when we want to do it next time. In a similar way, when we're working with these kids, we want kids to be making these accurate speech movements again and again and again and again on a really limited set of movements. We're not pulling out our super duper deck where there's 15 different things we're having them say, particularly again, if kids are just entering into spoken communication or they're very impaired. We're keeping our practice set very small so that they can have the opportunity to make those speech pathways again and again and again, so that they can feel what their mouth is doing, so that they can get feedback about what happened when I made that movement, so that they can stumble, get your assistance, get back up, and find that accurate pathway again. And it's through that process of saying things again and again and again, often aiming for 100 accurate trials per session, that kids are able to start to develop these skills. And that's just not something that you can do if this child is not seeing you very much. So that's the ideal. We want to give specific motor speech therapy 3 or 4 times a week to these kids. We want to be thinking really hard about what speech movements we're targeting, and we want to be supporting these kids using what's called the principles of motor learning. They've kind of stolen some things from the physical therapy literature, where people have actually studied like what's the most effective way to teach somebody how to jump or how to swing a golf club or whatever. And they've come up with some principles that they know about how our motor system acquires new movements. And they've kind of translated those to speech. And again, whole nother presentation there about principles of motor learning. But I bet you can find 1 or 2 free and good ones that I can refer you to. And the idea is that these are probably things that you're familiar with, but you might just be using unintentionally. And we want to be really intentional about it. And I'll give you one example. The difference between saying something like, yeah, that was it, versus, yeah, you really got your tongue up there, has been shown to have an effect on the motor system's ability to learn. Hey, you got that one, doesn't give the motor system as much information as, hey, you really got the tongue up. you got it right, yes, and here's how you did it. That's knowledge of results versus knowledge of performance. And basically, in using the principles of motor learning, we're going to manipulate that variable about when I'm going to give knowledge of performance versus knowledge of results alone. And what it does is it gives the child's system either more or less information so that they can make the next step on the next trial. Maybe they're able to do it with less support. We're doing this back and forth dance of I'm trying to get you to say book, and I'm trying to give you just enough support that you're able to say it. And then I'm going to pull my support back and see if you can still say it. Then I'm going to, if you stumble, I'm going to give you a little bit more support. If you're accurate, I'm going to have us do it a lot of times. And then I'm going to see if I can get it more to be a more complex motor plan, maybe by changing the prosody. But basically doing this therapy dance of pushing your motor system to the point where it starts to get a little shaky. And then I pull back a little bit and we get a lot of practice at that level. And then I see if you can fly a little bit further. And we kind of do this back and forth therapy dance that's very dynamic in helping a child's motor system to get accurate and more independent.
I love it that you said dance because jumped in and said that speech is an intricate dance. Exactly what you're saying. There is a dance between your brain and the mouth, and you're trying to build the. I like that analogy of the scarecrow, and when you have that path and you keep doing the same path, if you're going to run that path, like at first you're stomping slow, but once it's there and you see it, you're going to start running through that path. So I kind of like that analogy, meaning that they need multiple, and you said ideally 100 opportunities. And you're saying that they need, so when we're looking at frequency and duration, frequency, higher frequency, what about duration? If we,
if we can get the trials in, it's basically as long as that takes. So you might have the magical student who will just sit in front of you and say what you say when you say for them to do it. I would like to meet that child and have them teach my friends a few things. So, which is where we kind of get into the reality of things as well.
Yeah,
it's good to have that kind of ideal that we're aiming for, so that when we have to make modifications, we kind of know where we are and where we're headed. I think in the schools, if we kind of take that scarecrow analogy again, once a child is able to find that scarecrow, i.e. make that movement sequence with very minimal support, I might say to the SLPA or the special ed teacher or the classroom teacher, hey, here's a word that I would love Sally to be able to practice throughout her day. And what we've got there is we've got another opportunity to find that scarecrow without the whole level of support, because we know we've built up the accuracy in our speech sessions, but we know we need to generalize it outside of the therapy room and get some more reps onto it. And one thing that might be helpful is this idea of word buckets. If we've got word buckets where we've got 3 buckets, we'll call them A, B, and C. Bucket A is words that we know this child will be jazzed to say. We know they want to talk about Minecraft or Pokemon or whatever it is, and we're putting those, or their friend's name or their dog's name, whatever. That's in bucket A. Bucket B is from an understanding that we've developed from our assessment. Here is a level of practice that's going to be really helpful for this kid. Maybe it's CV, moving between consonants and vowels. So a word like wanna. It's a functional word. I want to do it. Wanna is going to be one of our words. Or maybe we take a Pokemon that has 2 syllables and we kind of pull it over, and it kind of matches our treatment target. And so we're going to practice it. Once we've got wanna to the point where this child is able, in what I'll call varied practice or distributed practice, which are 2 different principles of motor learning. But basically, we're not just drilling the same thing again and again and again, but I can pull out wanna any old time throughout my session, and this child's gonna be, with some very minimal assistance, able to say wanna. I'm gonna put it from my B bucket, which is the bucket that I'm working on in speech therapy sessions, to my C bucket. And C bucket words are words that the whole team is trying to carry over. So we've got bucket A, which is your dream words. Bucket B is your treatment targets that you're working really hard on. 3, 4, maybe 5 in your B bucket, and then they're moving to this C bucket, which can be words that are practiced throughout the day for those accurate speech movements, where we're saying, hey, you know what? If you hear this child say wah wah when they're kind of reduplicating instead of getting to their nose, here's the cue that's often helpful for us. Remember your nose sound, but it's that simple. They're not needing to pull this child into a speech therapy session. They're just needing to give a little reminder. Hey, the word is wanna, and if they slip into wah wah, you're reminding them to use their nose sound. Now everyone can practice that and get that to generalize beyond. The idea of a brag book is another way to kind of do some of this, where particularly for kids who don't have a lot of spoken communication, it can be really exciting to work on a word for a long time. And then, oh my gosh, we graduated this word into the brag book. We've got a picture for it. We're stapling it in, and you can show your family, you can show your teachers, you can show your friends, you got a new word in your brag book. And that's an opportunity to read through all of the words in my brag book. Those are words that I can practice now because I've worked so hard on them in speech therapy. So those are some ways that you might be able to leverage support throughout your school community to try to get some more of these accurate trials. But it really starts with the support that you're providing in the therapy session to build this accurate movement.
So I love what I'm hearing is you're saying that, yes, we're going to be doing the treatment words in the bucket B, but really it's a group effort in order to generalize, and that to get those multiple productions that we need to incorporate the teacher and the family. I love it. Right? I mean, we would do that. You're doing that in private. We would do that in the schools as well. Of course, we would want the teachers to generalize, and then getting the parents involved and knowing that the more that they practice at home, the more, the more treatment or the more positive outcomes we're going to see when we've got more practice.
Yeah.
Yeah.
And just the only thing that I'll caution is if these kids really do have childhood apraxia of speech, it is likely that they are going to need more support in order to move those words from bucket B to bucket C. And I would not want to rush them into bucket C and have them practice. Oh, you know what? They got all the sounds in wanna, right? But they did it as wanna in a way that, hold on, they got all the sounds there, wanna, but it's sounding awkward. It's sounding, instead of the stress on the first syllable, it's on the second syllable. It's kind of lengthened in a way that makes it sound awkward. We want to really make sure that it is the way that this movement is going to be incorporated into functional everyday speech. Wanna, and flexible. Wanna. They can kind of do it any old way, and they have access to that movement sequence before we push it and potentially have something be practiced as a
wrong. Yeah,
exactly.
I thank you for clearing that up. I love the clarity there. So if we could step back and kind of talk about, and I thank you, Courtney, because I was about to say about this bucket B words, because I know bucket A could be words the student wants to say and things that are important to the family and what have you. But when we're talking about bucket B, the words that we're going to work in therapy, how would we choose those? I like the way Courtney asked, are you choosing them based on the structure or high frequency words? How would you guide us on how do we choose treatment words for treatment?
Yes, all of the things.
All
There's
of it.
a lot of things to consider, but I love starting with what's going to be motivating and what is going to be functional for this child. That's a great place to start.
Yeah.
And then we know from our speech assessment, hopefully, that there is a point where things start to break down, whether it is getting into a syllable at all, whether this child is speaking more in vowels, but they can't combine consonants with those vowels without neutralizing that vowel, without it kind of slipping to and if that is, we've identified, hey, this child has this inventory of sounds, but when they try to create syllables, things start to get funky. That's where we want to be working. We're not teaching sounds, we're teaching movement in between sounds. So we're going to select probably a few CVs, maybe one VC, and that's where we're going to go. We're going to drill maybe 3. If a child is that impaired, it's probably only 3 or 4 different movements, starting with sounds that are in this child's inventory. We don't want to have to teach a sound while we're also teaching movement. We're going to make it easier by, hey, here's the sounds we got. Now we got to combine them. We're working on moving between them. And we're coming up with combinations of those sounds to create our practice set. That's kind of on the most basic end of things. I mean, I work with some kids on diphthongs, vowels with movement. Ow. Those are things that require very precise movement. And if you don't have the ability to know where your mouth is in time and space, it's like every time is the first time.
Right.
And as a result, you really can use some support in how to learn how to do that movement. So yeah, there is, I think it comes from a good assessment is where I'll land. A good assessment will tell you where you should start in your treatment, in what movement you should be targeting.
Marcia, thank you. Her question is, will working on one movement help other movements?
Great question.
Because I'm thinking like sometimes when we're looking at a student's phonetic inventory and we're looking at, they have so many sounds that they are having trouble. We might start with a harder sound, hoping that the easier will then generalize.
Yep. Yes. So we would like to see generalization. In the most impaired kiddos, you really do need to take a movement by movement approach, at least at first. Where you really probably aren't seeing generalization, you're just seeing improved movement on the targeted movements that you're focusing on in your therapy. But as kids develop and get more practice, they also are getting a sense of where these muscles are and how they move. How can I make a sound move a little bit more? And to the question that I think you had about jaw grading, how can I make my mouth open at a 3 or a 2 or a 1? I'm kind of holding my fingers next to my face for folks who might be just listening. But basically, there's different vowels that have different heights. And how can I do that without my jaw sliding to the side? Because all this, the joint tension that is required isn't established yet. And so I'm kind of like searching every time for how my jaw is, which is kind of almost like the floor from which I'm building this movement house is all shaky, which is going to make for some sound distortions. So there's lots of things to consider when thinking about treatment targets. And if you have a good evaluation and you spend a little time up front, the idea is that you will get some generalization. Let me just jump to the other side of the spectrum and drop this in. If you have a middle schooler or a high schooler or just someone who has more practice with speech, but you're hearing these kind of awkward movements, they've got plenty of sounds, but just the prosody is off, or maybe they are having difficulty with multisyllabic words. They have this diagnosis of apraxia. For them, you could select a couple words to drill again and again and again, or a couple phrases. It's my turn now. Or something like that, which is functional, and you get to drill it again and again. Or there's actually some cool research out there on a program called REST, which is somehow stands for Rapid Syllable Transition Training. It's out of Australia, and it has some good evidence behind it. But basically, what that does is it's all freely available and freely downloadable, and it's pretty straightforward, which is why I want to drop it in for any of the speech pathologists who have these kids who are more functional communicators, but just need help cleaning up their speech a little bit.
Did you say RSTT?
So the way they refer to it is REST with the E as little, because I don't think there's an E in rapid syllable transition.
Right. Okay. I think that I put it in like that.
There we go. So
okay.
And again, if you do a search for it, you'll get the whole treatment program popping up, and with a training module and videos and a lot of support. But basically, the idea is, hey, we are not even going to introduce real words, because those already have motor plans associated. What we're going to do is we're going to introduce nonsense words that you have never spoken before, and we are going to teach you how to say those words. And then we're just going to give you feedback on 3 things. Did you get the sounds right? did you have the beats right? Basically, did you have the right stress? And how smooth was your movement? Was your movement smooth? And we're not even going to get into the weeds of, hey, it was a little bit off, or hey, you almost had it. It's pretty straightforward. Yes, you got it, or no, you didn't. There's a little bit of training up front in terms of, hey, I'm going to teach you how to make these unusual speech movements. But then it's an opportunity for this older, more patient, more motivated student. Those are all the things that you kind of need in order to do this, to get feedback. When I said Bolido or whatever it is, Bolido, did I nail it? I say Bolido and you say Bolido. I say yes. You say Bolido. I say no. I don't tell you, hey, there was a little bit of a movement transition difficulty at the end there. I just say no, and it's up to your system to kind of tune in. Oh, I got all the sounds right. I think I had the right emphasis. And the speech system is responsible for identifying how they are either accurate or inaccurate. So that's on the other side of the spectrum. If you've got a student who isn't just moving into the beginnings of speech, but needs some cleanup work, I would encourage folks to check out REST and that's another one that I have seen modified, where there's the training and a little practice from the speech pathologists, but then with just a little bit more of a boost, an SLPA could pick it up and do a lot of the trials where they're saying yes or no, because they're not responsible for doing the principles of motor learning that are going to help this child establish those initial movements. They're just getting the reps in. So something like that is kind of the other end of the spectrum. And then there's everything in between.
It's huge.
Yes.
I know this is such a huge topic, and I know that you are really giving us a broad stroke. And
yes.
And because this really is, we can't possibly cover all of this in one, but I wouldn't mind if a couple of questions. I think the first one was talking about the jaw grading. I know Stephen is, my dog Stephen is deciding to join us. I think I thought I had him set up, but he's wanting to say hello. Tips on jaw grading. I like the way that you did with the fingers, like with the vowels. Is it a three finger vowel, a 2-finger, or one? I think that's a great strategy on giving a visual on jaw grading for a vowel. So I just wanted to, just in case somebody didn't hear it, I thought that was really awesome. And then when we're talking about, I'm just trying to think, I want to make sure I'm getting some of these questions, because there was one about how much verbal output does a child need. And you were talking about, we're working with children that have limited verbal output to children that are very verbal. So they don't have to be a certain level before we say, okay, we're going to give them, they would benefit from treatment.
Right. Yeah. And again, it's diagnosis is easiest when a child is able to participate in this back and forth dance, and they are able to produce speech that is across, single words to multisyllabic words, maybe to short phrases. But that's not to say that before kids are at that spot that we can't say, there's something with the movement going on here that is, I think, in need of support. I think I want to try some of these principles out. I think I want to see where we go when we try this. I have a suspicion that there's a childhood apraxia of speech, and you kind of take it from there. Because when kids get the early appropriate support for this movement, they have the best chance of taking off and running with it. Whereas if they don't, just because of the way their sound systems and their motor systems have developed to the point where you're seeing them, it's unlikely that they're just going to pick this up with time. They really need motor specific support working on movement.
This is a good one. Can a completely non-verbal student, high school, be diagnosed with apraxia?
I don't think so.
Okay,
You probably come up with other people who have different opinions. My sense, especially at the high school age, there's probably some other things going on with this child. And when we're kind of thinking about communication, big C communication, there's probably some other areas where I would want to be spending my therapy efforts, rather than seeing if I could help the motor speech system to learn how to move more efficiently. It's not to say that we couldn't do an experiment where we use some of these principles to see if I could get some more vocalizations, to see if I might be able to shape them. But I certainly wouldn't feel comfortable again because I just don't have that much of a sample.
Sure. And I think in the schools, we would be looking at, rather than getting tied up on, okay, we're going to make sure, we're going to be doing motor speech when we're looking at total communication. I think is what I'm hearing you say in some of these situations, right?
Yeah, but it is very challenging. And I know that there's families out there saying, hey, I want my child to talk. I
Yeah.
want my child to work on speech. And there's this diagnosis of apraxia that this child has because somebody diagnosed them with apraxia. And now it's up to you, school speech pathologist, to provide some education and say, hey, here's what we know about the way this young adult or this student's speech system has developed to this point. It's very challenging for them to coordinate some speech movements. And sure, we can give it a try. Let's really give a good, honest push to see if there's some of these tricks that I can use to help the speech system to move more efficiently. And if that isn't to work out, if it does work out, great, we'll run with it. And if not, it makes more sense for us to focus on functional communication rather than do something which is probably too hard, too frustrating, not motivating, or if it is motivating, again, too frustrating, and it's going to be torture for everybody.
Right. Because I think when we're looking at the school, so I just want to make sure because I think I'm like, whoa, this is heavy and huge, right? But if they have a apraxia of speech diagnosis, I think we're looking at, they might also have phonological disorder, articulation. There might be a lot of things going on.
Language impairment, cognitive impairment. They might have social communication deficits or differences, but there's a whole menu that you could be choosing from. And to say, hey, I'm going to make this student sit there and do repetitive back and forth speech production trials, you have to have a pretty strong suspicion that that's going to be worth everybody's time in order to put that child through that. So, I would hopefully be able to say, hey, here's where I think we're going to make the most progress, and here's why, and here's what we're going to do about it. And if we do get the pushback about, but I want my child to speak, great. Let's keep on checking in on the speech. Everything that we know about AAC shows that kids who have access become more vocal and verbal. So, hey, it's not like we're working against that speech goal by introducing the AAC or whatever else you're working on, but helping the family to see the place of speech in the greater scheme of communication.
Exactly, because I mean, our goal is for everyone to be an oral communicator. However, we don't just jump and say, oh, okay, we're going to do, that's our goal. We need to, like you're saying, is we need those foundations, and there's other things we can be working on in order to get communication. And those do build, just like you said, AAC does build on and assist with oral communication. Yeah. But I think it's hard because I think sometimes in the schools, like we might get a parent comes in with this diagnosis and says, okay, help us.
Yeah.
And then we need to sit back and look at, yes, that's one aspect of what's going on in this child's communication disorder. That's just one aspect. But then we can look at other aspects and say, bigger bang for our buck might be this. Yeah.
Right. And can we get in touch with the clinician who has diagnosed apraxia of speech and better understand where they're coming from and why they're thinking it's something that requires support in the greater scheme of things.
Good. Yeah.
Can they be the person, probably not for the nonverbal child that we've been talking about, but can they be the child for someone who does have apraxia, who is kind of quarterbacking from the outside saying, hey, here's our treatment targets. I'm working with this child once a week. You're seeing them 3 times a week at school. Together, we're combining our forces to get all of these trials. But the speech pathologist in the schools becomes someone who's putting into action a therapy plan that has been developed by someone who has either more experience or has fewer people on their caseload or for whatever reason, kind of making it work in that situation, I think is also a real good possibility to consider. I'm aware of the time.
I know. Oh man.
Before we wrap up, though, I did want to throw a few lifelines because this is all so confusing and overwhelming. and so outside of what folks are usually doing. It is a rare speech disorder, not so rare that you'll never see it. The prevalence estimates suggest that if you got a school of 100 kids on your caseload, 3 or 4 might actually have childhood apraxia of speech. And you can kind of math it out based on how many kids you see. But that's what the research suggests. And it's way too much to cover in a podcast. It's way too much to cover even in a single day session. But there is the Apraxia-Kids website that I mentioned that I'm a proponent of. There is something called the Once Upon a Time Foundation, which provides more intensive trainings around the country. I would encourage folks to look at Once Upon a Time Foundation. And then also, I am a resource. I have a Discord server, which is free to join for people who are interested in this space and want to talk to somebody.
What can I, let me put that.
Yeah, shoot me an email or go to my website. My website is brightspeechandlanguage.com. My email is mike@brightspeechandlanguage.com. So hit me up through either one of those channels, and we can get you connected with Discord. For folks who are unfamiliar, it's basically a place where you come and you can ask a question and get feedback from myself or some other people who are in that space. And that's a way to just kind of dip a toe in. And then if there are folks who know that they've got this on their caseload and they really are looking for some support in how to get started, feel free to reach out to me also, and we can see if we can coordinate something with your admin team about getting some ongoing training or get some support. And that is something that I'm very happy to provide as well. So
I love it. Yeah, I started throwing those in. So those are in the chat, guys. Apraxia-Kids, Once Upon a Time Foundation, and then go to brightspeechandlanguage.com. Click on that. That'll take you to Mike's website. Loads of stuff there. Mike, this was a huge topic. I know, but you know what? I'd love to get you on again. There's so many other aspects we could talk about. And, you know, it is one of those low incidence, but high impact,
exactly.
You know, and so I think you've definitely given us somewhere to start and some great ideas. I love it. And I want to thank you so much for your time. I know that we are at the end. I just want to remind before we leave to remind those that are here, and we had a lot of listeners. Thank you everybody that came today. That I want to make sure that you are going to get your credit. So be sure to go to Speech Therapy PD account and fill out those modules to make sure you get your credit. And if of course you like it, I want people to review and like and tell your friends. I want to see everybody on the next episode. Mike, again, thank you so much. I hate to say goodbye, but we got to say goodbye. Thank you so much, everyone. Bye, guys.
Bye-bye.
Thanks for joining us on today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Also, please don't hesitate to tell us which topics you would like us to cover in future episodes. To get in touch, drop us a line in the comment section or send us a message on social media.